right. Good afternoon, everybody. This is Jose Maimani, and today I have Dr. Gerlinde Tynan, who's one of our breast cancer surgeons here at Rocky Mountain Cancer Center in Longmont, who's presenting on the topic of breast cancer surgery. Dr. Tynan did her medical school training at the University of Washington and did her residency training in Arizona. She has been in practice now for 14 years and has brought very important certification processes for breast cancer care to Arizona when she was in practice there, and as well here in Longmont, and has really elevated our breast cancer care locally. She is now part of Rocky Mountain Cancer Center for almost the last year, but has been in practice here in Longmont for about 5 years and has served the patients here in Boulder County. It's been a privilege working with her directly. She's wonderful with patients, and the patients always compliment her on her surgical techniques and her bedside manner. Today, she's going to be talking about the role of surgery in breast cancer, and specifically delving into lumpectomy versus mastectomy. So I'm going to go ahead and hand everything over to you, Gerlinde.
Okay, great. Well, thanks, Dr. Maimani. Appreciate the nice introduction. I'm going to go ahead and pull up a little slideshow here for everybody. 1 second. Okay. All right. Let me just, sorry, move my camera here. It wasn't on the screen I expected it to be on, but there we go. All right. So, yeah, I'm Dr. Tynan, and I'd like to talk today about lumpectomy versus mastectomy. I think that sometimes when I'm seeing folks in the office, some people have some preconceived notions about these two procedures, and I'd like to kind of talk about both, and so that folks have a better understanding of their options. And the wonderful thing about breast surgery, I think now that is different than it traditionally has been, is that we have so many different options for treatment that really most people, we can really find something that really works for them. So with that being said, I'm going to start off with a couple of statistics. So the most recent American Cancer Society statistics on breast cancer are here. So breast cancer is the most common cancer in American women, other than skin cancers. And the risk of developing breast cancer is about 13%. And so another way of looking at that is to imagine that 1 in 8 women will develop breast cancer in their lifetime. So if you take like myself, yourself listening there, and then 4 of your friends, that would make, or sorry, 6 of your friends, that would make 8 of us, and then 1 of us will develop breast cancer. Most women will have an acquaintance or family member that has gone through this. So, and then below we can see the statistics for how many cancers will be diagnosed this year, at about just over 270,000 cases in the U.S. Most will be invasive breast cancer. It's a little bit different than non-invasive. And of those 270,000 plus women, about 42,000 women will die from breast cancer. Trends in breast cancer death. Breast cancer is the second leading cause of cancer deaths in women, with lung cancer being the only one that beats it out. However, the chance that any one particular woman will die from breast cancer is low, about 2.6%. So most women actually do very well. A lot of that is because of early detection. And then that kind of, the next sentence discusses that a wee bit. Since 2007, death rates have been steady in women younger than 50, and much of that has to do with the fact that those women tend to get more aggressive breast cancers. But we see decreases year after year in older women, about 1.3% per year in that 4-year period they mentioned there. And a lot of this is, again, from detection at an earlier stage, as well as better treatment options. Okay, so some ground rules for our discussion. Breast cancer has some complicated factors to it. And so, again, one of the good things, like I said, about breast cancer is we have many treatment options, but that also could make things a little complicated in that one woman's breast cancer is not going to be the same as another woman's. So this talk is going to kind of cover our standard, more common type of breast cancer. So in other words, number one, early stage cancers. Breast cancer has 4 stages, 1 through 4. They're split up into stage 1A, 1B, 2A, 2B, etc. Until you get to the later stages, they actually add a C. But we're talking about early stage breast cancer. So in other words, breast cancers that are relatively small, may or may not have minimal amount of lymph node involvement, and typically have what we call kind of favorable tumor biology. All right. That also then leads into kind of our straightforward breast cancer. So our ductal carcinomas in situ, our invasive ductals, invasive lobulars, which really encompass the majority of breast cancer, the vast majority. We're not going to talk about malignant phylloides or sarcomas or other very rare breast cancers that these, general rules are not going to apply to. We'll also talk about, when I talk about lumpectomy versus mastectomy, kind of the standard ages, women between, late 40s to, mid 70s or so. We're not going to talk about very young women or very old women because we sometimes do things a little differently. And then another really important thing to remember is the difference between recurrence and survival, okay? So when we talk about survival from breast cancer, it's pretty straightforward, right? We're talking about whether or not your breast cancer is the cause of your death, all right? Versus a recurrence, really we're talking about a local recurrence, meaning does the breast cancer come back within the breast or the remaining skin or the chest wall, all right? Because breast cancer coming back in the breast does not necessarily mean, in fact, does usually not mean that a woman is going to go on to die from her breast cancer. And you'll see why that's important when we talk about lumpectomy versus mastectomy. And then the other thing to remember when we talk about the surgical approach to what we do with the breast is that is typically not going to affect whether or not you need chemotherapy or whether or not you need, what we call biologic therapy, which is like, Herceptin or some of these other treatments. The only really difference we see in the other treatments that are needed based on what we do surgically is with DCIS, which is the ductal carcinoma in situ. Typically, women who have a lumpectomy with DCIS will need medication as well, whereas women who have mastectomies for DCIS typically don't. But really, that's the only difference. Okay. So let's start off just a little bit of anatomy of the breast so that we can understand some of the terminology. The breast is a gland that lies on top of the muscle. So you can see here, this is the front view, all right, breast with the underlying tissue. And this is a view from the side. Nipple is here. This is the gland itself lying on top of the muscle, and here are some ribs underneath, all right? And so the breast itself is made up of the lobes or lobules and the ducts, which make up the gland. And then we have fatty tissue, some kind of supportive tissue around that. The ducts come from the lobules or the lobes and lead to the nipple. All right, this is the nipple. The brown area around it is called the areola. All right, so let's talk about a lumpectomy first. So a lumpectomy is where the tumor, the cancer, and a rim of normal tissue around it is removed. It's taken out in one piece. All right, we don't want to ever cut into the cancer. We want it to remain kind of embedded, if you will, in a rim of normal tissue. The reason that is we want those margins or that edge of the tumor to not have cancer in it. And so we take it out in one piece. That way the pathologist can check all the edges to make sure there's no cancer remaining. There are different ways that what we call localize the tumor. With our advanced imaging, especially with our 3D mammograms, we're finding breast cancers most of the time before we can even really feel them. So in order for me to find exactly where that cancer is and remove it, again, encased in a normal rim of tissue, I can't be just kind of, feeling my way around there and taking out things piecemeal. We really want to be very precise in how we remove it. So we'll talk a little bit about how we use ultrasound in the operating room. We'll talk about wires, and then some other newer techniques, scout and seeds. There are also some oncoplastic techniques that we use. These are newer techniques that, number one, take into account the cosmetic outcome of the surgery, as well as the cancer outcome, if you will. So in other words, it's important to get all the cancer out, but we also want to make sure that the breast looks nice afterwards. Also, some of these oncoplastic techniques allow us to do surgeries that maybe we couldn't do before. In other words, a very large tumor can be removed from the breast, and we can still move things around to make sure the breast still looks nice, whereas in the past we would have recommended mastectomy. Lumpectomy is a same day or an outpatient procedure, so there's no need to stay overnight in the hospital. We can combine lumpectomy with sentinel lymph node biopsies or full removal of lymph nodes. It's kind of that's sort of a separate procedure, but they're done at the same time, which you'll see also is the case with mastectomy. In order for a lumpectomy to have equal survival to a mastectomy, and I'll get to that in a minute at the bottom here, radiation needs to be added to it, okay? Now, again, we're not talking about extremes of age. Sometimes in much older women, we can forego the radiation, but generally speaking, if we do a lumpectomy, even though we take out that tumor and we do get all the tissue around it clear, meaning have negative margins, radiation is still needed. The reason is you still have that breast tissue left. And if there are a few cells that are a little further away from where the main tumor was, those need to be treated somehow. And the radiation will, quote unquote, kind of sterilize the remaining breast tissue. Traditionally, we did 4 weeks of whole breast radiation, meaning the entire breast was radiated, oftentimes some of the lower lymph nodes as well. That was done Monday through Friday. Used to be 6 weeks. Most of the time we can do it in 4 now. And then some patients, many patients in fact, can have what we call accelerated partial breast radiation, in which the radiation is delivered twice a day over a 5-day period only. And that is just to the lumpectomy cavity and a small rim, about 1 centimeter of tissue around that lumpectomy area. And again, in order to do these more precise type of procedures, so for instance, this accelerated partial breast radiation, we need to really make sure that the radiation oncologist knows where that cancer was. And so that's where these, we call them radiographic markers, the Biosorb and the Veriform are the 2 I'll talk about. Those come into play. All right, so again, lumpectomy, survival is equal to mastectomy, meaning the chance of dying from breast cancer when you have a lumpectomy plus radiation is the same as having a mastectomy. So patients will sometimes come in and they'll say, you know, I want to do whatever I need to do to live, to survive my breast cancer. And so, you know, we have to talk about the fact that if you do a lumpectomy with radiation, your chance of surviving your breast cancer is the same as if you do a mastectomy. Now, there is a higher risk of the cancer coming back within the breast if there's breast tissue remaining. But again, that's not what causes us to die from breast cancer. If the tumor comes back in the breast or you develop a second one, we can take care of that again. Oftentimes we can do repeat lumpectomies with radiation. Maybe we'll do a mastectomy at that time. But the overall survival is equal in both procedures. So women do not need to feel like they've got to have a mastectomy in order to save their life. That's just not accurate in the vast majority of cases. Okay. So a lumpectomy, also called breast conserving surgery. So traditionally, we did lumpectomies where if this is the breast tissue and this is the tumor, and again, we want to get a regular rim of tissue around it, we would make an incision directly over the top of the cancer. And sometimes that's still the way we do it. It really depends on multiple factors. And then the rest of the breast remains, and then that's where the radiation comes in. Now, there are other techniques, and this just happens to be one of them, called hidden scar, which I've done that training, but it's a nice slide. So, and then we do what we call more cosmetic incisions. All right, so almost as many times as possible, I'll either make an incision here, and then we do some extensive while you're asleep in the operating room, so you don't feel any of this. Some tunneling over to where the tumor is, and then the tumor and that normal root tissue can be removed here, taken out through this incision, and then we do some work underneath the skin to reapproximate that tissue so that you don't get a divot. That's a nice way to do it. The other nice way to do it is under here, okay? Make an incision in what we call the inframammary crease. So again, very less visible. We can still, you know, this is nice with a tumor like maybe over here or over here. Sometimes we can do from here, and if the tumor's far out, I might bring this incision down a little more actually, but then I can often get lymph nodes out plus the tumor out through the same incision. So how do we find these tumors? Most tumors, like I said, are not palpable or can't necessarily be felt at the time that we see you in the office or at the time of surgery. Sometimes breast cancers that are somewhat that we can feel, we will use ultrasound in the operating room to help guide the margins. So for instance, when we look at this ultrasound, this is our cancer, right? Very typical looking cancer on ultrasound. Here's the skin at the very top, all right? And this is the breast and fatty tissue mixed in. So when I run my fingers over the top of this, so let's pretend here I'm pushing on the skin here, I'm going to feel that hard mass underneath. But using ultrasound in the operating room helps me really to say, okay, this one's fairly deep. You know, I've got a good amount of tissue on top, so I can go down fairly deep before I have to start taking out this area. But by the same token, what I would also see is say, you know what, there's this little additional little, like this little, you know, this little tentacle that's coming up here. I want to make sure I get that in there. And so if I didn't have that, I would have a little more room here. But since that, then I would want to make sure that I include, you know, a little extra tissue on top to make sure I get all of that. So ultrasound is very helpful. We know that use of ultrasound in the operating room decreases our what we call positive margin rate. What that refers to is we go in, we take out the tumor, and when the pathologists look at that rim, if they see additional cancer at the top, that means we have to go back and take more tissue, and we really don't want to have to do that. Now, again, most cancers we cannot feel. And so up until just recently, for those type of cancers, we had to do what's called a wire localization, all right? So this is kind of an example. So this shows a wire that's placed by the breast radiologist. Typically, sometimes surgeons do it, but more often now it's the breast radiologist that do this. This is the clip or the little biopsy clip that was left in place at the cancer at the time of the biopsy. There is this I cannot feel, okay? This is too small to really be useful as far as surgically. It's useful if we're looking or following an area on mammogram that perhaps came back as benign, but as far as using this to find the cancer, it doesn't help me a whole lot. It does, however, help our breast radiologists be able to localize this. So what they do, they numb up the area, they place this little wire through the skin, it's got a hook on one end, and then I can look at this and know that I need to take out this area because it's, you know, so, you know, X number of centimeters from, say, you know, where it enters the skin. This is kind of an illustration showing that. So in the time in the operating room, there's that wire that goes through the skin into the tumor. So I can make an incision directly where the wire goes in. Typically, I'll actually make my incision here, all right, and then under the skin, tunnel over to where the wire enters, and go down like this. And they're kind of showing it here, and then remove that tumor with some tissue around it. Let me go back. So wires are great. We've used them for, you know, years and years and years. I did them all through residency and in training and all of the rest. But the wires have certain disadvantages to them. This wire is actually literally kind of poking out of the skin. It has to be taped down to the chest, and then the patient has to go from the radiology area to surgery with this tape over their chest. There's chances the wire could move. And so one of the things that we use now is called the Scout device. So basically, this is a radio frequency transmitter. Okay, see how small it is? There's a dime that is placed, can be placed, you know, days ahead of the surgery into the tumor. It then emits a signal, and at the time of surgery, I use this probe, and then the probe picks up that signal. It gives me a distance away from the tumor plus the sound that it makes, and then I can decide where I want to approach that tumor from. Do I want to come straight up from the top? Do I want to come in from the side? But then that obviates the need for that wire sticking out of the skin. It's a little tricky to get used to using, but it's like anything else. Once you do a lot of them, then you get the hang of it. So now here's an example of what I was talking about, these oncoplastic lumpectomies. So sometimes what we'll do is we'll combine our lumpectomy with, say, a breast reduction. Let's say that we have a patient who has large breasts, okay, and they have maybe a large tumor, say here in the breast. And so previously, back in the old days, if you will, a very large tumor, we probably would have done a mastectomy. And then you say, then you have this, you know, asymmetry, kind of lopsided. Rather than that, what we do now is we do oncoplastic techniques. Some of these I do by myself, some of them I do in conjunction with my plastic surgeon. So basically what we would do, if the big tumor was here, we would remove all of this tissue. We would remove more tissue to make a reduction out of it, and then do the same thing on the other side. So at the end, then we have a smaller breast here where the cancer was removed, but we also have a nice symmetrical smaller breast on the other side. And the nice thing about this is, first of all, insurance covers this, okay? It's not considered a cosmetic procedure because it's really being done for your cancer. And so we, don't have, I see women who have had surgery many, many years ago, one breast is much, much smaller than the other because of a big tumor, or they underwent a mastectomy when now we can do things like this to help save the breast. Obviously, if there was a tumor here, the patient would still need her radiation afterwards. But again, she's symmetrical and got a breast reduction out of it as well, which is a nice little side benefit. All right. So markers. So let's go back to where we had, all right, our tumor. Let's say we have a tumor here that I went ahead and I made an incision here to remove the tumor. So from the outside, all that you would see is a little scar here. All right. If we want to do that targeted radiation where we just want to radiate where the tumor was, how is the radiation oncologist going to know where it was when the incision is over here, right? So that's where these radiographic markers come in. This is a biosorb, one of the ones that we use. It's either a spiral or more and more we're using these more what we call low profile ones. They're flat. They actually, these do poke up a little bit, so it's about this thick rather than the bigger spiral. And the purpose of this is we place that in the lumpectomy cavity, okay, close up the tissue around it. And then if my incision now can be, it doesn't really matter where my incision is, if the radiation oncologist can then find it by looking for this marker. And so when the radiation oncologists do their planning, if you will, for radiation. So in this case, what the surgeon may have gone in up here by the nipple. And so you can see kind of this like scarring, or what we call just post-operative change from the fact that they, went in there and then went down to where the tumor is. But here we have that biosorb, which is in the tumor bed, which clearly identifies the area to be radiated. So now the radiation oncologist can target and then just apply the radiation here. There's a newer one called the Veriform that I've just started using. It's the same idea, but instead of being that spiral or that little lattice that you saw, which is a little firm, and sometimes patients can feel that, this is basically a suture that serves the same function. So this is an illustration of putting it in the breast at the time of the surgery. You put it into the lumpectomy cavity to mark where it was, and then here's how the radiation oncologist sees it. Both are great. They just are different applications. Sometimes one patient is suited better for one than the other. Okay. Now there are certain limitations to lumpectomy still, even despite the things that we can do. Breast size. So traditionally, if the tumor was greater than or equal to 25% of the total breast size, we would not recommend lumpectomies just because there would be such a big size discrepancy with the other breast. But again, with some of our techniques where we can get around that size discrepancies, that's not a hard, fast rule anymore. Again, a large lumpectomy can result in asymmetry, which can lead to more procedures, either to fix the asymmetry or to reduce the other breast. So those are things that we would talk about in the office. Sometimes tumor limitations. Sometimes the cancer prevents us from doing a lumpectomy despite some of the things that we can do. A multifocal cancer would be where you have the main tumor and then little specks of tumor around it. That can be turned into a really big size that needs to come out, and sometimes a mastectomy is better for that. Multicentric tumors. What this means is that there are multiple tumors in different areas of the breast and the whole breast is more or less involved. Inflammatory breast cancer is another what we call contraindication to lumpectomy. That's where the skin of the breast is involved with cancer, and it's very difficult to get clear margins with a lumpectomy for that. So we do mastectomies for that. And then those few patients that have what we call persistently positive margins, meaning we go in, we do the lumpectomy, but the edges are still involved with cancer. We'll only do that like twice before then I recommend a mastectomy. And because the radiation is needed, some people who cannot have radiation, for instance, in pregnancy, we don't do radiation. And then some of these other conditions will not allow us to do repeat radiation, or if you have scleroderma. Again, even with prior radiation, sometimes we can often redo radiation. So, but these are things that we would have to discuss and make sure we're on the same page with our radiation oncologist. All right, a mastectomy. So what is done? All the breast tissue is removed. Sometimes women forget the breast goes all the way up to just beneath your collarbone, all the way to the armpit area, kind of underneath to where that inframammary crease is, or you want to call it the bra line. So all of that breast tissue is removed. A variable amount of skin is removed. So sometimes we do kind of a traditional old-fashioned mastectomy, all the breast, all the excess skin is removed, resulting in a straight line across and flat chest, all right? That's usually a simple mastectomy. A modified radical mastectomy is where we take all the lymph nodes as well. And then a radical mastectomy is where the muscle is also removed. These are very, very rarely done anymore. I think in my career, I've done, I don't know, maybe 4 of them. If patients have tumors involving the chest wall, typically we have ways, chemotherapy or other ways that we can shrink that tumor down so we don't have to do these horrible surgeries anymore. They really are not something I like to do. So after a simple or modified radical mastectomy, some women do not do a reconstruction, they just wear a prosthesis. Others will do a delayed reconstruction. Maybe they change their mind later, or there are other reasons that we don't do a reconstruction right away. We can always do a reconstruction later. So we're not burning a bridge if we just want to do the simple mastectomy. And sometimes people just want to do what needs to be done right now, and we can do other things later. That's okay. However, we also have what we call skin sparing or skin and nipple sparing mastectomies. This is where all the breast tissue is removed. We still remove all the breast tissue, but we can leave the skin envelope. Sometimes we can even leave the nipple and areola on the skin envelope and then perform what's called an immediate reconstruction where that's done right away, okay? All of these almost always require an overnight stay in the hospital. We can combine this with lymph node surgery, post-operative radiation, again, for early stage breast cancer is typically not needed with mastectomies. That's one of the benefits of it. Again, survival is equal to a lumpectomy with radiation, right? Because survival has to do with if breast cancer is elsewhere in the body, not the breast itself. There is a lower recurrence rate, meaning the chance of breast cancer coming back in the reconstructed breast or along the skin or muscle is lower just because there's, in theory, absolutely no breast tissue left, right? All right, here's some examples. So this is our traditional mastectomy without a reconstruction. So sorry, it's a little blurry, this picture. Here is the incision that we make. All that breast and excess skin is removed. Then this end of the incision is brought together here to make a straight line across like that. All right, that's a good old-fashioned mastectomy from 50 years ago, but sometimes which is still done today in the appropriate case. Our mastectomies with immediate reconstruction. Nipple sparing incision is done here in the inframammary crease. So the incision is made here. Then I go underneath and remove all the breast tissue from underneath the skin. Okay, but we leave the skin in the nipple. My plastic surgeon then comes in and through that same incision does the reconstruction here. All right, and so when it's all said and done, all you have is this little hidden incision. Very nice procedure. Skin sparing incision. Sometimes we cannot save the nipple areolar complex. Maybe the tumor is too close to it. Maybe our patient has a lot of sag and instead of the nipple being here, it's kind of way down here. In those cases, we'll do what's called a skin sparing mastectomy, where an incision is made here. It might be a little bigger if there's a lot of skin that needs to be removed. All the breast tissue is then removed. Plastic surgeon uses the same incision to do the reconstruction. And then these two edges are brought together and the result is just a straight line across the front. We can do nipple reconstructions. We can do special 3D tattoos. There's an entire world of options out there after this procedure to just to make it look a little more natural since there's nothing on the front. Some of the reconstruction of options, tissue expander, breast implant. That's the most common, what most people do. A much less complicated type of surgery, less recovery. However, there are still flaps that are done. We have latissimus dorsi flaps. We have different kind of tram or abdominal wall flaps. We have gluteal flaps. Basically, this is where skin, fat, and muscle are taken from these areas and then implanted here. Okay, so the downsides of mastectomy, more aggressive. Some women say, why would I want my entire breast removed if it's just a small area of tumor that could be removed? And that's true. It is much more healthy tissue removed. Really depends on someone's approach to how they want to deal with their cancer. Some women want to be very aggressive. Some women want just the minimum done to, get them through it. Mastectomy is definitely a longer recovery. It's not a quick outpatient procedure. It's an overnight stay in the hospital, depending on if there's a reconstruction. It's a good 3 to 6 weeks of limited activity. It's not terrible. You're not bedridden, but there are definitely some restrictions on lifting. There might be some work restrictions, whereas lumpectomy, most people are kind of back to normal within a week or so. The other part of mastectomy is it's definitely a difference or a change in your body image. One of the reasons that we have developed these immediate reconstructions is because of body image. Instead of having, being flat-chested for 3 months until you get a reconstruction, if we can do an immediate reconstruction in a patient who wants to be reconstructed, it's just so much nicer. You leave the hospital with breasts, okay? They're not, they're not your real ones you had before, but it is something. From the exterior, at least, people feel like they look normal, okay? They can wear normal clothing. They don't feel like a cancer, side effect as much, if you will. So but there is a body image change. Even though they're nicer, can look very cosmetic, it's still not your real breast tissue, still not, the sensation is not the same. If patients decide not to do a reconstruction, then there's the question, do I want to wear prosthetics? Do I want to just go flat-chested all the time? Do I maybe get, a prosthetic bra for special occasions like my daughter's wedding, that sort of thing? So those are things to take into account. And then sometimes, depending on, our size going into it, so women who are have a little excess tissue to start off with, sometimes that side tissue underneath, when you don't have a breast, that kind of pulls our little chubbiness on the side away. When there's no longer a breast there, sometimes that little extra tissue remains, and sometimes we have to do special things to take care of that tissue. Okay, so in summary, I kind of put this together here. Lumpectomy versus mastectomy. Lumpectomy is less aggressive versus a mastectomy. That can be good or bad depending kind of on your outlook on how you want to deal with your breast cancer. There's definitely a shorter recovery with a lumpectomy versus a mastectomy. Most lumpectomies do need post-op radiation, which again is not necessarily a big deal, but it is part of the process, whereas most mastectomies do not. Breast size limitations are tumor to breast ratio. We talked about large tumors and small breasts, or large tumors and large breasts, and then do we have asymmetries to deal with? Whereas mastectomy, there's the tumor size doesn't really matter because all the breast is being removed. The only limitations that we'll see are whether or not we can do a skin sparing versus a nipple sparing in those that do reconstruction. We have tumor limitations with lumpectomies. If we have these multifocal or multicentric, where there's multiple tumors in the breast, sometimes we can't do lumpectomy. If we have inflammatory breast cancer, we don't recommend lumpectomies. Whereas with a mastectomy, none of that really matters because all the breast is coming off. Again, women who can't have radiation. So pregnant women, we do not do radiation on, period. And then some of these other things. Prior radiation, sometimes we can or cannot. Scleroderma, lupus. Women are more likely to get mastectomy if they have genetic predisposition to more cancer. Some women have genetic mutations that make them highly likely to get breast cancer again. And so sometimes they'll just go ahead and do, say, a double mastectomy from the get-go, even if they have a small tumor at their diagnosis. Lumpectomy, rare again with the techniques that we use now, but sometimes we have difficulty getting a clear margin, and sometimes that leads then to a mastectomy. Lymph node treatment is similar for both. And again, cannot stress enough, equal survival. So you do not make a decision on whether to have a lumpectomy or a mastectomy based on your fear of dying from breast cancer, okay? Tumor biology, lymph node status, those are the things that matter more as far as your survival. Choosing which surgery you have on your breast, that is the smaller part of overall survival from breast cancer. So really our goal is to find lumpectomy or mastectomy, whatever works for, for you in your time that you have your breast cancer. You should not make a decision based on worrying about dying from breast cancer, because we can make sure you do okay, all right, with a lumpectomy or a mastectomy. So that was my talk. If you guys have any questions, I think Dr. Maimani is going to let us know.
Gerlinde, thank you for that. That was very comprehensive, very patient-oriented. And I think that last slide about comparing the two is really helpful for patients and for them to review before they make that surgical decision. It seems like in the field of breast cancer surgery, we've kind of slowly moved towards, less is more. In the old days, you do this big radical mastectomy, and over the years, doctors have fought for patients to do less, and save some of those side effects. But there's a recent trend, I think, in patients doing more, bilateral mastectomies for early stage breast cancers. Is that a trend that you've seen locally, and what are the discussions that you've had with patients? Do you feel a lot of that is related to cosmetics with mastectomies, early reconstruction can, like you had said, sometimes you can get a little bit better of a cosmetic result depending on the patient.
Right. Yeah, I would say that's definitely true. It's interesting, like back in the 1970s, especially women in rural areas, there were a lot of mastectomies. Some of that I think had to do with maybe lack of access to radiation or, surgeon preference. And so there's been, in the breast surgery world, there's a big push for more lumpectomies. Okay. And so, for a time there, and in fact, even now, we do track our mastectomy rate. Okay. If we have more than 50% of our patients getting mastectomies rather than lumpectomies, as far as accreditation bodies for like NAPBC, they look at that and they say, well, why are you doing that? And I think that goes back to that fear that previously women weren't really offered the opportunity for a lot of reasons. So for some time, I saw a lot more, I wasn't practicing in the 70s, but when I did, go into practice, I would say we did more lumpectomies. I do think we do a little bit more mastectomies now. And I think part of it is that, the reconstruction options are much nicer now. So, that's just pretty straightforward. The other thing is, I actually think that patients are much more educated about their disease. I think they understand recurrence rates, what that really means, the yearly mammograms, the callbacks. I think that they understand that more. And also, I think in general, plastic surgery has become a lot more normalized than it was previously. So I would agree that we see more. Again, I always have that conversation with patients to make sure they understand why they're doing one versus the other.
Right. We don't have any questions listed just yet, but
Okay.
As you mentioned, I think the most important thing is individualizing the case. Every patient is different, the anatomy is different, the biology is different, the staging is different, and really having a team-based approach and looking at every case individually is probably the most important thing. And you guys have done a wonderful job here of doing that, with every case. I think, with our breast tumor boards, when you present those cases, those are all, the plans are always very thought out. And as a team and as a group of oncologists, we review those cases together and try to make a team-based approach. So we don't have too much in the way of comments.
I just wanted to actually piggyback on what you just said about that. One of the things that we've started doing here as well is our multidisciplinary breast clinics. And so many times the patient who comes in for that first visit, I'm seeing them. Our Dr. Weeks, our radiation oncologist, is in the room as well, and then our medical oncologist, yourself, mostly Dr. Robinson's, Sarah. Right. But we see them together. And so I can talk about the different options. Dr. Weeks can weigh in on what she feels about how the, radiation, the best approach there. Dr. Robinson might say, maybe this is a case where we should do chemotherapy first to shrink the tumor. So really, again, it is, you're right, very individualized based on exactly what that particular patient has and also how they kind of want to navigate through this. It's a shared decision-making process for sure.
Right. Yeah, it's, things have changed dramatically in the last 30 years, going from, sending everyone a radical mastectomy to actually talking with the patient and finding where their values are and what their opinions are on surgery. It's, medicine's just changed so much. So, well, I don't think we have any questions, and I genuinely appreciate you doing this talk. I think we'll save this talk, and a lot of patients, I'm sure, in the future will look at the PowerPoint and we'll find it helpful. So again, thank you, Gerlinde, for doing this. And if anyone has any other questions, they can feel free to post them, and we can always send those over to Dr. Tynan at a later date.
Thanks a lot, Hossein.
Okay.
All right.
Thanks.
Bye.